So one of the things that, once you've been diagnosed with Barrett's, right, then the next step is to figure out, do you have anything that requires treatment or eradication right now? Like, do I have a cancer? Do I have dysplasia? And so if you do have something right then and there, then we will send you to the appropriate therapy. If it's advanced, if it's a true cancer, it might be surgery, but most often it's some form of dysplasia. And then we usually, as I said, we can manage that endoscopically. And so the term that's used is something called endoscopic eradication therapy, or EET. And through a combination of either cutting things out or burning or freezing them, we can pretty much get rid of all the abnormal Barrett's tissue over a series of procedures, usually 2 to 3 procedures, sometimes a little more if it's longer, spaced about 8 to 12 weeks apart. So, but what about the group of people? That's only a small number of people. That's maybe 5, 10%. Most of the rest of the people will not require any immediate treatment. And so then the question is, well, what are you going to do now? I have Barrett's, I have a precancerous condition, but you don't need to do anything right now. Well, when should we look? How often should we look? So forth. Right? So currently, patients who are felt to have no dysplasia or have low risk molecular testing can undergo surveillance every 3 to 5 years. And then they would come back, they would get those biopsies, like we talked about, every 2 centimeters, 12, 3, 6, and 9 at each level, 4 biopsies per level. And then maybe they would get brushings and other things like that. Now, you might say, well, wait a minute, you said 3 to 5 years. Who's 3 and who's 5? I mean, there's a little bit up to the discretion of the physician, but typically we make that decision based on the length. So if you have 3 centimeters or less of Barrett's, we typically call that short segment. And if it's short segment, you get to go a little longer. So it can be up to 5 years. Okay. Whereas if you have more than 3 centimeters or more, we call that longer segment or long segment. And those people we typically bring back at about 3 years. Okay. And so that is kind of how we do that. If you've got a patient with dysplasia, most of the time, at least my practice, I recommend considering eradicating it because our techniques are so good. But if there's a patient who says, Doc, I don't know, yeah, you told me I have low-grade dysplasia, I'm not convinced I want to do it yet, we bring them back at some more frequent surveillance interval, usually 6 to 12 months in those situations, and then kind of go from there. So that's kind of some of the general strategies on how often to look. And we typically follow people until age 75. And then after 75, it really depends on their health at that time to see how much further to go.
Now, in tandem with that surveillance plan, are there any other interventions or medications that people have to take, or dietary or lifestyle changes that go hand in hand with this?
Yeah. So as we talked about, this is all about reflux, right? So it's all about managing your reflux. Okay. So, and again, for those who have symptoms, we want to control those symptoms. And for those who, don't have symptoms, we typically put them on medications because we think they have silent reflux. And they're a little bit harder because it's hard to have a patient take a medicine when they don't really feel any benefit from it. Whereas if you're having heartburn, it's like, oh, I feel better. So typically we put people on one of these PPI, proton pump inhibitor medications, right? And typically once a day is fine, usually 15 to 30 minutes before their first meal of the day. If their symptoms are more at night, sometimes we have them take it before dinner. And then, if you take the medicines religiously, you should be able to have a little liberalization of your diet. But I think we know the usual suspects: caffeine, chocolate, tobacco, alcohol, fatty foods. So these are some of the things: citrus, licorice. There's a variety of things that can be associated with increasing reflux. So perhaps, keeping an eye on your diet, along with some lifestyle choices like not eating and lying down right afterwards, eating smaller meals, as well as taking anti-reflux or anti-secretory medications, can all help in sort of controlling the reflux, which may help preventing the Barrett's from getting longer or progressing into further stages of dysplasia.